My name is Phillip Stricker. I've been treating patients with prostate cancer now for over 30 years. I dedicated my practice to prostate cancer almost 30 years ago. And in that time, I've been passionate about, one, introducing new therapies, which are less invasive, and two, keeping all the information evidence-based. Naturally, I've also been passionate about delivering each treatment in the best possible way with the least possible side effects and keeping a very close follow-up so that publications on the outcomes can always be made. With over 200 international publications now, I'm continuing to tailor the therapy of prostate cancer so that the right person gets the right treatment at the right time. From a personal perspective, prostate cancer is a tough journey for men. It really requires not just a urologist, it requires a team of people to look after patients properly. I'm so privileged to have that team working with me. People like Jane Matthews, who's my clinical manager for over 30 years. People like Anne-Marie Haynes, who's been collecting data on the patients for almost 30 years. My administrative staff, sexual health physicians such as Michael Lowy, Stuart Baptist, pelvic floor physiotherapist, and all the other support people in the ward and the hospital and in my office who constantly support every patient who goes through. In addition, I'm also privileged to have a research team who independently keep the outcomes of all my patients. Headed up currently by Shika Agaral, she coordinates all the fellows who often are doing PhDs under me to make sure that we collect all the data and, if we get insights, research those insights, or if we find a new treatment, to evaluate that treatment. So some of the major changes I've been involved with have been introducing radical prostatectomy, robotic radical prostatectomy, brachytherapy, both high dose rate and low dose rate, active surveillance, transperineal biopsies, modern imaging techniques such as MRI and PSMA PET scanning, and most recently, of course, focal therapy with the nanoknife. All of these have been introduced very carefully with evidence. And I'm most proud of the place that we find ourselves now, 30 years after the beginning of this journey, when patients did badly and had very, very limited options and suffered with terrible side effects. Let me run you through some of the advances that I've been heavily involved with and that we've published internationally on. Firstly, transperineal biopsy, a more accurate and safer way of doing a biopsy. This now is the gold standard across the whole of Australia. Secondly, brachytherapy. Some people would know it as radioactive seeds. This minimised the side effects of radiotherapy in the late 1990s. Thirdly, robotic radical prostatectomy, which is a minimally invasive way of doing a total removal of the prostate. And whilst it didn't definitely have major advantages when we first introduced it in 2006 in New South Wales, it's been proven subsequently to minimise the side effects of surgery and speed up the recovery after surgery. Next, of course, the recent introduction of focal therapy in select patients to minimise the side effects of surgery and radiotherapy, and to do that as a day procedure safely. And just to give you some ideas of numbers, having done over 2,500 robotic radical prostatectomies, over 1,000 brachytherapies, over 10,000 transperineal biopsies, and over 600 nanoknife procedures, and in those cases where we can just monitor cancers, called active surveillance, over 1,400 cases. So I find myself in a very privileged position to be able to help individual patients to decide which is the right treatment for them at that time. Having been the head of the MDT clinic, this is known as the multidisciplinary clinic, where all specialties come together and discuss cases, for over 20 years, it enabled me to get a good understanding of how to tailor the right treatment for the right patient at the right time. Another recent development in the area of radiotherapy has been the MR-Linac machine, which we've been privileged at St Vincent's to be one of the first units in Australia to have. We've now done almost 200 cases, and we've been able in 10 days, as opposed to 8 weeks, treat patients with prostate cancer with radiotherapy, avoid damaging certain areas such as the urethra and the bladder neck, which cause all the side effects, and have them in and out in a much shorter period of time. And we're yet to prove that it's got less side effects, but the early data are very strongly supporting that. You may wonder what an MR-Linac is. So what it is combining technologies. It's combining an MRI machine which sees the cancer and sees the prostate with a radiation machine which treats the cancer. If you can see the cancer and the prostate while you're treating it, it's clearly going to be more accurate. This is the first time these two machines have been linked. One of the things that I'm extremely keen on is evidence. There's no point introducing a technology without proving that it's actually beneficial. I've been extremely privileged over the last 20 years to be the director of the St Vincent's Prostate Cancer Research Centre and a team of researchers, and working with two universities, the University of New South Wales and the University of Sydney, and working with the Garvan Institute of Clinical Research, to be able to not only form one of the largest tissue banks and databases in the world, but also to have a team of researchers who independently assess each one of the technologies that we've introduced. Being the director of this, it's been incredibly satisfying to watch new treatments become accepted as the evidence becomes proven. One of the great challenges for prostate cancer moving forward is, one, to see it better with better imaging, and we're working on that all the time, trying to improve MRI, PSMA PET scanning, and some newer technologies, one of which is called the synchrotron, which as yet is only experimental. As well as improving imaging, we're trying to improve therapies. Now these therapies can treat the local cancer, or they can treat the whole person and target the cancer. Another new exciting development, which we're currently researching with our medical oncology colleagues, is the use of a new novel anti-androgen called an N-chain anti-androgen. This has the potential for increasing life expectancy even in the most advanced parts of the disease. This is a first-in-world experience, and whilst we don't know what the outcome is, we're happy to test it in an evidence-based way, and hopefully will continue to move prostate cancer from the days where most people died to the current days where we can treat almost any stage of prostate cancer.